First, thank you for coming and thank you for the invite. My name is Mark Russell. I recently retired from the Navy 6 months ago, and I serve as a military psychologist and been in the military for about 26 years. And what I wanted to talk about today is just give you a voice, and this voice is coming from a mental health clinician in the field. When I was deployed at the start of the invasion in Iraq, I was deployed with a field hospital. When I showed up, I was the head of the mental health services. I was the only mental health provider for that. It's a 250-bed hospital, and I had a couple of enlisted technicians that worked with me. That was my contingent. When I was there, we built up our field hospital. These were tents, and we were all assigned places to go to set up our shop, where we're going to have, the ORs and the nursing wards and so on, where was mental health clinic. Mental health was the last to be chosen. In fact, my name wasn't even called. As all my peers, medical peers and nursing peers scrambled off to set up the hospital, I was the last one left standing, waiting to be told, well, where is mental health going to be? And the response was, I think a rather candid response from the medical officer was, well, we're not really sure why you're here in the first place. And I'm thinking, well, here we are preparing to go to war. We've actually been in war already since 2001 with Afghanistan. This was prior to the Iraq invasion. And we were questioning what is the legitimacy of mental health in treating wartime issues. When I got back, I started surveying around my colleagues in mental health in the military and how many had been trained to treat PTSD, for example. By that time, in 2004, the Department of Veterans Affairs and DOD published their guidelines for treating PTSD. And they identified 4 evidence-based treatments that have been shown to be effective. And I surveyed 133 clinicians, and out of the 133, 90% had not been trained, given any training on how to treat PTSD. The former Undersecretary of Defense for Health Affairs, Dr. Winkenwetter, in July 2004 states that the military health system is committed to doing everything possible to help our service members remain healthy, including providing access to high-quality mental health services. Both my experiences and many of my peers in the trenches of mental health took issue with that. And, of course, the survey findings I mentioned. Question was why? We were short-staffed to begin with. Up to the war, we were actually cutting mental health billets in the military. And, in fact, the internship site, which I was at in Portsmouth, Virginia, was abolished. And at that time, we were also contemplating eliminating all the social workers from the military. It kind of flew in the face of a growing mental health demand. My last duty station was in Japan. I was stationed there on a Marine base. I was the only psychologist for a base of 8,000 personnel. I was on call 24/7 of the emergency room pager. And so, for the last 4 years, basically that's been my life. We were mandated to see at least 8 mental health patients a day. And so we were listening to many of the stories and narratives a day. And that was in addition to whatever administrative or other types of duties we had. We were facing, at that time, a very high attrition rate. Mental health providers were leaving the services at high numbers. According to the Navy specialty leader, we were losing 5 per month were requesting to get out. When I decided to speak out publicly about what was then a mental health crisis that was ready to explode, we were staffed about 60% as far as mental health billets. According to Secretary of Defense Gates, who gave a speech in October of 2009, the DOD has doubled its ranks in terms of mental health clinicians. Despite the doubling, we are still 30 to 50% understaffed to meet mental health needs in the military. Now, while everyone has said about the effects of war and trauma and PTSD is just one of many different aspects of going to war. It's not the only. I understand we have veterans from Korea in here and Vietnam. These are not new lessons to learn, but we were not prepared to meet mental health needs in this war, as we were not prepared to meet them in Vietnam and Korea, World War II, despite these lessons that were supposedly learned. I filed a grievance against Navy Medicine in 2005, alleging gross negligence of mental health care that was damaging to veterans and their families. As a reward for my speaking out, I was given some reprisal and got me to an early retirement out of the military. A sacrifice I knew was worth it, and I was predicted. What are some of the issues? What I was bringing up is more, yes, we need staffing, we need training, we need services, we need a lot of things, but these are nothing new. And so I was more focused, well, why is this happening again? We had the same crisis after Vietnam, had the same crisis after Korea, after World War II. You see the same headlines about suicide rates and the need for new VA and military clinicians. We see the same repeating of history. And the question was, why? All right? And we don't have time, with my allotted time, to go into that. But I will say a lot of it has to do with the fact that there's a disparity between mental health and physical health. It's been around. In the military, it was cemented by 1916, but it's pervasive in Western society. We treat mental health illness as something unique and separate than the body and medical illness. And providers of mental health are treated in a lower priority, given less value. We compensate them less. In the military, a medical provider can get anywhere between $40,000 to $400,000 in a bonus for their specialty pay. In mental health, for psychotherapists, which are psychologists and social work, who do most of the psychotherapy in the military, you're looking at maybe a $5,000 bonus maximum, right? Very, very wide gaps in terms of the value we place in mental health care and psychotherapy in general. The military has not made it its mission to provide psychotherapy early intervention. It's only recently, because of the media and because of congressional acts, that we're now trying to staff the resource to provide it. My concern is that if we don't address the root causes of why we have this repeating of history, and why mental health is neglected, and why we have to go through these crises, that when the war stops and the media starts to turn its attention to other things, we will be back to complacency, and then come the next generation, we'll have to refight the battles that many of you here are fighting about. And so my reason for speaking out, my reason for coming, was just to have us focus as a voice, but what is the reasons for why we're fighting this battle again. In the staffing issues, if I have just a couple more time, just to kind of whet the appetite, in the military we have a lot of social workers and marriage and family counselors that are employed by the Family Service Centers and Marine Corps Counseling Centers. That's separate from the military issues. These are DOD civilians. These are licensed professionals. Many of you are probably social workers and MFTs. You know that you have a license to treat PTSD and other types of conditions. In the military, we do not allow it. Okay? So what happens, we have thousands of clinicians who are licensed to treat and diagnose mental health conditions, but they're not allowed to practice. Right? They're allowed to treat adjustment disorders or marital problems, family problems, but not allowed to treat PTSD. When I'm at that base in rural Japan, my last 4 years, I was the only psychologist, and I'm keeping up just with new referrals. So for treatment, there was nobody there to provide treatment except myself. I could provide it maybe once a month. I can have a therapy session as follow-up. There is a great fragmentation of mental health care in the DOD, in the transition between DOD and VA, and that will be talked about later. But what we need, and what I've asked for, is that there be a separate corps established in the military, like we have a medical corps, we have a nursing corps, we have a J corps, a legal corps, right? We have these special corps, but we don't have one for mental health or behavioral health care, and that it's time to elevate the profile and the priorities in mental health care. What that means is that if we don't, and we have fragmented care, that we don't have the right hand and left hand talking to each other. And we expend a lot of resources, and we duplicate programs in the military that are having to be reinvented all the time. So I would just advocate again that we look at the root causes, looking at disparity and the underlying issues to why we're here.